Hey, good morning, everyone. Welcome you all in Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and today we are discussing and continuing our series of AIIMS DM Neonatology Fast Track Revision, in which we have discussed many topics. Today's topic is neonatal eye diseases, neonatal skin diseases, and some neonatal hearing disorders and their managements. Okay, so this will be very interesting session. If you haven't watched other videos of this series, please watch them, and it is very important to revise them before exam. So just do like, share, and subscribe, and we'll without wasting time, we'll start our amazing lecture today, which is on eye, ophthalm, ear, and skin diseases. Okay, so let's start without any delay. First thing first, eye examination or eye disorders in neonate. Retinopathy of prematurity is very actually important topic for examination as well as your clinical practice point of view. So we'll understand ROP in detail today. Okay, so the first slide is looking congested, but I'll break it down in different portions so you will understand. Okay, so what happened in retinopathy of prematurity? Any neonate having receiving oxygen, blood transfusion, other risk factors are there. Retinopathy of prematurity develops. How we will examine this patient, this neonate, as retinopathy of prematurity? How we will divide? Okay, first we have to divide this of whole eye retinal image into three zones, basically zone 1, zone 2, and zone 3. Just be with me. Okay, so I'm zooming this image. Just understand what I'm trying to tell you first. So guys, this is optic disc. Okay, all we are agree, this is optic disc. Just nearby optic disc is macula. So this is optic disc, this is macula. Okay, so the zone 1 definition, we will switch actually slides in between, so just stay focused. This is very much interesting, and after understanding it is very easy. Okay, so zone 1 is circle with an optic nerve at its center radius that is twice the distance from optic nerve to macula. Okay, so this is actually optic disc, this is macula. So the distance is twice 1 and 2. Okay, so distance is twice, that is the radius. So zone 1 radius, it encircles that optic disc, and it is radius is twice from the distance of optic disc to macula. Okay, understood? So this is zone 1. Okay, we'll talk about zone 2 now. Okay, zone 2 is concentric ring-like area from edge of zone 1 to nasal ora serrata and similar distance superiorly, inferiorly, and temporally. Okay, this is actually zone second. Posterior zone is also found, which is area size equal to distance of two disc diameter. Okay, don't worry, I'll explain to you this. Okay, what happened in zone 2? Zone 2 basically it is encircling zone 1. Okay, so zone 2 definition is, this is ora serrata, this is nasal margin of this retina, so this is ora serrata. So the ora serrata, starting from ora serrata to concentric circle around zone 1 will be called as zone 2. This will be symmetric, like zone 1 was symmetric, this is also symmetric round. So ora serrata distance, this distance, it will start from this. You are able to see the red color of thing is zone 2, the zone 1 is seen in green color. So ora serrata, from ora serrata to circling whole zone 1, it is zone 2. Okay, but in zone 2 actually posterior zone is there, which is 2 disc diameter wide. Okay, if we see optic disc is this, 2 disc diameter wide is zone 2, which is posterior part. Okay, so zone 2 has posterior part which is of 2 disc diameter width. Okay, going forward to zone 3. Zone 3 is remaining crescent shaped area of retinal periphery of from zone second. Okay, the remaining this area which is shown in yellow color, which is crescent shape, and this will be called as zone 3. Okay, first I want you to clear on zone 1, zone 2, zone 3. Again to revise, zone 1 is around optic disc and its diameter is 2 times of optic disc to macular distance. Zone 2 is encircling zone 1, which is starts from ora serrata and all through encircling zone 1. Zone 2 having posterior zone which is 2 disc diameter, and remaining crescent shape area is zone 3rd. Okay, uh, actually this is, I think it is clear about zone of retinopathy of prematurity. We'll discuss them in detail also. Okay, then after zone we have discussed. So zone, I think you have to be clear. So this is optic nerve diameter, ora serrata. These are keywords. Okay, crescent shape area. All are good. Severity. Okay, though severity is classified as stage 1, stage 2, stage 3, stage 4, stage 5. Stage 1 is thin white demarcation line separating vascular from avascular retina. Okay, so this is just keep concentrating on this diagram. This is, you're able to see, this is thin demarcation line which is actually separating avascular retina to vascular retina. So this is stage 1 of severity of ROP, very much important. Stage 2, what happened? This line becomes some elevation, has got some elevation, so it became ridge. Okay, so this is stage B. So as stage 2 is addition of height and width to demarcation line of stage 1, it is called as ridge. So ridge is basically next step after stage 1 where line become ridge. What is stage 3? Extraretinal fibrovascular proliferation, which start from abnormal vessel extending from ridge to vitreous. So this is extraretinal fibrovascular proliferation. Are you able to appreciate this ridge? Yes, this is ridge. Sorry, this is ridge, and this is extraretinal fibrovascular proliferation. So, in these two conditions, you are able to see stage 3 ridge with extraretinal fibrovascular proliferation. This is important to understand. Going back, stage 4. Stage 4 is partial retinal detachment. If it is not involving macula, it is 4A. But if it is involving macula, it will be called as 4B. Going towards this, this is subtotal retinal detachment. You are able to see ridge and you are able to see all these things. If it is not involving macula, it is 4A. If it is involving macula, it will be 4B. Understood? Okay. Then stage 5 is complete retinal detachment. So in this condition, stage 5A, 5B and 5C are given. 5A, optic disc is visible by ophthalmoscopy. 5B, optic disc is not visible. And stage 5C, anterior segment changes like marked anterior chamber shallowing, iridocorneal lenticular adhesions will be seen. In nutshell, 5A, optic disc is visible by ophthalmoscopy. 5B, optic disc is not visible by ophthalmoscopy. And 5C, anterior chamber changes. Let's see in this. This is actually total retinal detachment. In this condition, this is the classical picture of total retinal detachment. Okay, 5A, optic disc is visible by ophthalmoscopy. 5B, optic disc is not visible. And 5C, anterior segment changes. Dilatation, tortuosity of retinal vessels you are able to see in this image. So you have to remember, you have to actually go through with all these images, these can be asked in exam and are important for practical point of view. So we have understood what are the zone looks like, what are the zones, and what are the severity of form staging in ROP. Okay, so this we have understood. Now we will move forward another things which are actually included in definition of this. Okay, so first thing is, what is plus disease? So plus disease is presence of dilatation and tortuosity of retinal vessels at posterior pole of eye within zone 1. Okay, so this is actually posterior pole of zone 1, which is having dilatation and tortuosity of vessels, will be called as plus disease. So in this diagram you are able to see dilatation and tortuosity of retinal vessels. Okay, so this is dilatation and this is tortuosity of retinal vessels. You're able to, I think you're able to differentiate between them. So this will be called as plus disease, and this is seen in posterior pole of zone 1. See, stay very attentive. If you find anything which is not you're not able to understood, just pause this video and revise this again. You will understood this condition, you will understand this condition. Actually this is very important to understand. Okay, what is pre plus disease? So you don't have to remember pre plus disease. Basically pre plus disease is less than what is plus disease, so you need not to remember. Okay, first I'll talk about extent. Extent of ROP in 30-degree clock hours, a total of 12 clock hours of 30-degree each. So I'm going to first diagram. I will actually keep switching the slides because it is important to understand concept rather than mugging up that. Okay, so these are actually clock hours, 3, 6, 9, you understood. Okay, so one clock hour is actually divided into 30-degree. Total 12 clock hours are there. We'll understand them, how they are important in our discussion or our management point of view. Okay, so going back to in this, so we have understood till now what is plus disease, dilatation, tortuosity. We have understood what is extent of ROP is classified as clock hours. 30-degree clock hours is considered as one, and total 12 clock hours which are 30-degree each. Okay, so what is notch? This was PYQ long back. So this notch is inclusion of ROP lesions of 1 to 2 clock hours into more posterior zone. So this is classical definition of notch. Okay, one term is mostly used by ophthalmologists. This is aggressive ROP. Okay, what is aggressive ROP? Aggressive ROP is severe plus disease. Okay, so plus disease we saw. This is dilatation tortuosity of retinal vessels in posterior pole of zone 1. So severe plus disease plus neovascularization. So this is very important. Okay, if severe plus disease means dilatation tortuosity is there along with the neovascularization. Generally it is seen in posterior zone 1 and 2nd. That's why sometime or in older literature it was also called as posterior aggressive ROP. So it leading to retinal detachment. Okay, so this was definition of this. Okay guys, if you are having hard time to understand this, it's okay, because we all are pediatrician. We are not ophthalmologist, but we have to understand the basic actually terminology and how it is uh, how the zones and severity is classified, because after all it will help in our clinical practice and clinical acumen managing ROP newborns. Okay, so going forward, yeah, so going forward in this direction, we have, yeah, so we have seen the definition of aggressive ROP. Okay, this is similar, plus disease plus neovascularization posterior zone. What is threshold ROP? Okay, one more definition. Threshold ROP is recommended as Basically, previously threshold ROP was used, but now it is pre-threshold ROP is used. Okay, so pre-threshold ROP, what is pre-threshold ROP? Pre-threshold ROP is the similar thing in which we use treatment protocols accordingly. Like, this is very important. I'll take to you first slide. Okay, so ROP, retinopathy of prematurity, basically we classify this into type 1 of retinopathy of prematurity and type 2 retinopathy of prematurity. Okay, each type 1 and type 2 is subdivided into zone 1 and zone 2, zone 1 and zone 2. Okay, so type 1 retinopathy, if zone 1, any retinopathy of prematurity with plus disease will be called as type 1 ROP, or stage 3 plus minus plus disease, usually stage 3 without plus disease will be called as zone 1 type 1 ROP. In zone 2, stage 2 or 3 with plus disease, so this will be called as type 1 ROP. Type 2 ROP, zone 1, stage 1 or 2 without plus disease, and zone 2, stage 3 without plus disease. Okay, so this is also definition of pre-threshold disease, which is new terminology used nowadays. And what is the treatment? Treatment is simple. Is this for type 1 ROP, peripheral retinal ablation is done, and type 2 ROP, continuous monitoring is done. Okay, so we understood zone, we understood stages. What you have to remember this, how they are classified, plus disease is also required in classification. So what you have to remember, just pause this video and just revise this actually flowchart. This is very important. This is divided into zone 1 and zone 2. Once you are thorough with it, your actually treatment plan will actually simplified into this. If it is zone stage, sorry, if it is type 1 ROP, peripheral retinal ablation will be done, and if it is type 2 ROP, it is actually continuous monitoring. So this is how many questions can be framed in this ROP topic, and trust me, you have to revise it once again, and it is basically simple, but once you understood, it is go to thing for you. Okay. Okay, so going forward, we have seen pre-threshold ROP. Okay, so these are actually retinopathy of prematurity imaging. So in A or B image, actually plus disease is present in both left or right eye. Plus disease means retinal tortuosities and bending of vessels are seen. And in this image, pale pre-retinal fibrovascular tissue posterior to stage 2 ridge at the end of retinal vessels. So ridge you are able to see, and fibrovascular tissues, this is pre-retinal. Okay, these images can be asked in exam. Just go through them once. Okay, so this is of our concern. How you will dilate eye? Ophthalmologist will say, please dilate the eye. So the medicine used is phenylephrine, that is 2.5% concentration, along with topicamide, that is 0.5%. You have to put them 2 times at 10-minute interval, 30 minutes before procedure. So this is simple, you have to remember this. Okay. Okay, this is pediatrician neonatologist thing. Oh, so we are very comfortable in this. So what are the screening protocol? Screening will depend on gestational age and birth weight. So these actually important for consideration. There are two protocols. Rashtriya Bal Swasthya Karyakram RBSK says any neonate less than 34-week period of gestation or birth weight less than 2 kg, or if he or she is 34 to 36 of period of gestation, along with the risk factor. What are the risk factors? You have to remember them all. Respiratory support is more than 6 hours, sepsis, apnea, blood transfusion, exchange transfusion, and unstable neonate. You have to remember them all. These are risk factor if they are present in 34 to 36 week of gestation. You have to actually do retinopathy prematurity. Okay, what AIIMS realized that these are two strict criteria, so AIIMS revise them, and generally in AIIMS it is followed that less than 32-week period of gestation they'll do screening, okay, or if baby weight is less than 1.5 kg they will do screening, or the 32 to 35 period of gestation plus the risk factor mentioned they will do screening. So we have two specific protocol, one is used by RBSK and one is used by AIIMS. In exam if they specifically ask RBSK protocol, just go through RBSK guidelines, and they if they don't mention anything just go with AIIMS guidelines. Okay, second thing, when to screen. So if your baby is less than 28-week period of gestation, or birth weight of baby is less than 1200 gram, okay, so then you have to screen this neonate at 2 to 3 week postnatal age. Very important, early screening is required in neonate born less than 28 week of gestation or less than 1200 grams of birth weight. In other condition, in other condition, newborn born after 28 week of gestation of more than 1200 grams birth weight, 30 2 week postnatal age, or 4 week of postnatal age, whichever is later. So you have to remember this was PYQ. It is not which is earlier, it is later. 32 week of postnatal age or 4 week of postnatal age. This is actually I am correcting it. 32 week of post menstrual age and 4 week of postnatal age, whichever is later. You have to screen that child in this time frame. So these are screening guidelines. This slide is very important and have potential to actually potential of many question in this slide. Okay, so what is the treatment? We have discussed also. In type 1, we'll do peripheral retinal ablation. So what is type 1 ROP? We just understood basis of John stage and plus disease. Please go through that classification once again, which is very important. Type 2 ROP, just observation is required with serial examination. Okay, what are the treatment modalities? This is retinal ablation, and this was previously asked which laser is used. So this is double YAG laser is used. Okay, anti-VEGF drug. So they do regression of abnormal vessels. So what anti? There are list of drugs, but generally bevacizumab and ranibizumab is used. Okay, so how we will prevent this retinopathy of prematurity to basically? So judicious use of oxygen in preterm neonate should be done according to the SpO2 protocols after hours of birth. Okay, so generally seen PaO2 is more than 80 is associated with this retinopathy of prematurity. The PaO2 should be less than 80. Okay, adult RBC transfusion having more 2,3 DGP, which releases more oxygen, leading to more damage. So blood transfusion protocols are under should be under strict criteria or guidelines. We do not need to over transfuse the neonates. Okay, vitamin E and reduced ambient light exposures are not effective, not studied so much. Okay, so this was retinopathy of prematurity. I'm again urging you all just pause this video here only and revise this retinopathy prematurity from starting from this video. It is about 20 minutes lecture of retinopathy prematurity. You have to revise this again, and if you revised it thoroughly, so you'll be very well versed with ROP, and this is very important for your exam and other purposes. Okay, now we will go to a smaller topic which is easy for us. This is actually conjunctivitis. Okay, so we'll talk about this. Chemical conjunctivitis is generally non-infectious lid edema, watery discharge there. No treatment is required. Gonococcal conjunctivitis, it is important. Generally onset seen after 3 to 4 days. Just remember. Okay, it is clinical presentation, marked lid edema, copious discharge, and it can perforate cornea. So this is important. Anything which is life threatening or life vision endangering is important to understand. The treatment of gonococcal conjunctivitis is ceftriaxone 25 to 50 milligram per kg daily intravenously. Very important. This was PYQ also. And topical antibiotics used only if corneal ulcers are present. So this gonococcal, it onset in 3 to 4 days, marked lid edema, copious discharge, can perforate cornea, ceftriaxone IV is treatment of choice, and topical antibiotics used in corneal ulceration. Chlamydia trachomatosis, it is the most common cause of neonatal conjunctivitis. Just remember, onset is 5 to 7 days after birth, it having lid edema, pseudomembranous formation, and pneumonitis after 3 to 12 weeks. Okay, immunofluorescent assay, GIMSA stain, basophilic intracytoplasmic inclusion in epithelial cells are pathological findings. Erythromycin or azithromycin are required for a treatment of choice of this chlamydia. Okay, this is most common cause of neonatal conjunctivitis. Others are like strepto, herpes simplex. These are actually not that common, but you have to remember gonococcal and chlamydia, the clinical features and treatment. Okay, so now we are moving towards to ear. So this the first left-sided diagram. This diagram actually is not important for exam, just to aware you all, because it is also used in clinical practice. This is normal actually conversation. These are decibels given, and these are hearing loss, range of hearing loss. This is normal hearing loss. This is mild, moderate, severe, profound. So this is normal range, okay, and this is mild, moderate, severe. Any piano, any truck, rusting leaves, bird chirping, whispering, crying. So these some things are there. So this is actually your practical point of view. What is exam point of view is grade of hearing loss, very much important. So, if no impairment is 25 decibel or better, so it is no hearing loss. Slight impairment seen is 25 to 40. You can remember 25 to 40. Moderate impairment 40 to 60 decibels. Severe impairment 60 to 80 decibels, and profound impairment including deafness is 80 to more than 80. So you have to remember this was asked twice in exam, and it is very important to understand this 25, 25 to 40, 40 to 60, 60 to 80, and profound including deafness more than 80. Okay, so what we'll do, audiometry, that is autoacoustic emission and automated auditory brainstem response screening, OE and AABR we will do. Okay, so in audiometry, OE, what we do, signal to noise ratio is actually calculated. Okay, early diagnosis is important of hearing loss, because hearing aids, if at all they are required, they generally put at 6 months of age. Okay, so what is OE? Sometime it is asked actually what is the definition of OE. So OE is physiological response of outer hair cells of cochlea. This is not inner hair cell. This is outer hair cell. And what is ABR? This is response of cochlear auditory neural functions to brainstem. Does OE detect sense SN hearing loss? This was previously year asked question, and it is actually very controversial. But OE and AABR both detect sensorineural hearing loss. But auditory neuropathy, if you require auditory neuropathy beyond ear, Nowadays OAE doesn't can't do that, but ABR can do that. Okay, so OAE threshold to fail is 30 to 35 decibel hearing loss, and ABR threshold to fail is 40 to 45 decibel hearing loss. So recommended for NICU screen? No. In sick neonates, you have to go for BERA or AABR, and in well baby screening, you can do both. So this is very important. I'll go through the slide or flow chart for hearing screening. Okay, just stay attentive. If hearing screening, if your neonate is at low risk, well newborn, you can use audiometry. But if your newborn is at high risk, use both audiometry and BERA EBR. Okay, so if you are using OAE, so if it is passed, okay, it is okay, but it is negative or it is not passed, it is called as refer. You have to do both audiometry or ABR, or audiometry you can also repeat if you found you did early. Okay, you did after second time your OAE or ABR failed, so you have to do diagnostic ABR, very much important. So audiometry means OAE failed, you can repeat audiometry after like 1 to 2 months, and after that if it also failed you have to do ABR. Okay, but in high risk neonates, you have to do both. If it is pass, yes, this is okay. You have to do counseling. But if it is referred, you have to do ABR, and if it is referred, so you have to do ABR. Okay, so at 1 month of age, it is done. After 3 months, then 6 months. So this is sequence of 1 month, 3 month, and 6 month. Genetic workup, physical examination is also required. Okay, so hearing loss can be conductive, hearing loss can be sensory during hearing loss, hearing loss can be mixed. So in conductive hearing loss, medical and surgical intervention is required for hearing aid and bone anchored hearing aids, BAHA. SN hearing loss, if it is mild to severe, hearing aids required which assess candidacy for cochlear implantation. But if in SN hearing loss, severe profound loss is there, cochlear implantation is required. Okay, in hearing loss that is mixed, hearing aid implantable device, and you have to cochlear implantation actually candidate you will choose. So these two flow charts which are important for consideration of neonatal or infantile hearing loss, low risk, high risk screening, how you'll proceed. Okay, now we'll see some slides on dermatology of a newborn. So in this, we have discussed this. This is actually your skin structure. This is epidermis, this is dermis, hypodermis, hair shaft. We are all well versed with it. We have to see what is the prematurity effect on skin physiology. Skin thickness is 0.9 millimeter in premature, but in term it is 1.2 millimeter. Epidermal thickness is just half of term, that is 20 micron. Epidermal covering, no vernix caseosa is seen before 28 week. It is very important to prevent heat, losses of heat. Okay, transdermal epidermal water loss, just see the difference at 26 week of gestation, 45 gram per hour and 4 gram per meter per hour in term neonate. So much difference means this is very huge. Acid mantle is also incomplete in premature. That's why premature screen is more prone to dehydration and water losses. Okay, so these are some fetal skin embryogenesis milestones which are important. Okay, in this condition, just remember expression of epidermal keratins in scene is 6 weeks. The important is formation of dermoepidermal junction is 8 to 10 weeks. Beginning of nail development is 10 weeks. Beginning of hair development 12 weeks. And Sweat gland formation in rest of body is 24 to 6 weeks. So understand this. At 24 to 26 week of gestation, fetal skin is generally well formed, and maturation takes 2 to 4 weeks after exposure to external environment for a preterm or term neonate. Okay, so we'll discuss some percutaneous absorption in newborn. This slide is important for exam also, but this slide is actually important in clinical day-to-day practice also, and this every pediatrician neonatologist should be aware of these condition. Okay, aniline leads to methylglobinemia if your patient is exposed to mercury. In which products mercury is used? Diaper, rinse, teething powders, rash and hypotonia can occur. Laundry disinfectant, one laundry disinfectant is pentachlorophenol is there. In this condition, what happen? Tachycardia, sweating, hepatomegaly, metabolic acidosis, even death can occur. Boric acid, which is used in baby powder, causes vomiting, diarrhea, erythroderma, seizures, and death. Lindane, which is used in scabies, cause neurotoxicity. That's why we use 5% permethrin in neonatal scabies. Salicylic acid, which is used in with dermatologists, this is keratolytic emollient. It causes metabolic acidosis and salicylism. Okay, silver sulfadiazine, which is used in burns, it causes kernicterus because it having sulfur compound, very much important. Povidone, iodine, all we know, it is used in betadine. It causes hypothyroidism and goiter. Benzocaine and prilocaine both use methylglobinemia. So, methemoglobinemia is caused by this aniline, benzocaine, and prilocaine, three drugs, which is important. Okay, these are some images of neonatal skin conditions. Okay, first thing in this first diagram, you are able to see. Okay, this is erythema toxicum neonatrum. These are actually pinpoint pustular lesions, ill-defined erythema having actually eosinophils. You're able to see this is erythema toxicum. If you are see this is erythema and trunk or extremities. Okay, this is actually transient neonatal pustular melanosis. These are discrete pustules on non-inflamed base. Are you able to see? There is no inflammation. There is no inflammation. Just pustule is there. Some are ruptured. Okay, or some are having residual hyperpigmentation. So this classical description is neonatal pustular melanosis. You have to remember there is no underlying inflammation at base. Okay, this is another image showing eosinophilic pustular folliculitis. In this, these are also eosinophilic rich and erythromatous papules. Generally, these are found on chest. So you have to remember this diagram. This is eosinophilic pustular folliculitis. Okay, this is infantile acropustulosis. This is discrete grouped erythromatous papules and pustules on sole of foot. You can found this erythromatous papules on sole of foot. So this will be called as infantile acropustulosis. Okay, this condition is miliaria crystallina. In this condition, it found numerous, there are many discrete, easily ruptured superficial vesicles. So, if this condition is found, this is miliaria crystallina. Okay, this condition is milia. You are able to see numerous, discrete, pinpoint, monomorphic, white papules around the eye. So this image you have to remember. This is milia. Okay, these are Epstein pearls, discrete, opaque, white, keratin-rich papillary nodules along alveolar ridge of mouth. So these are Epstein pearls. Okay, this is sebaceous hyperplasia. This is found around sebaceous triangle of nose, which is this pinpoint yellow macules. Okay, This is seborrheic dermatitis, waxy, yellow, loosey, adherent, scaly plaques on erytheromatous base on forehead and scalp. Very important. Okay, this is neonatal cephalic pustulosis, which is called as neonatal acne. So this is actually classical picture of neonatal acne. These are Herculean color changes. You are able to see unilateral macular erythema along the trunk. So these are Herculean color changes. Okay, cutis marmorata. This is common condition found in neonatal NICUs. Reticulate viloceous erythematous patches on upper extremity. Okay, so this is subcutaneous fat necrosis, browny indurated erythematous plaque on black back of otherwise healthy infant. And this is dermal melanocytosis, also caused as Mongolian spot. These are gray macule and patches on back of healthy infant. Okay, so these were some common condition, skin condition, which are fairly common. One more extra point, humidity in NICUs is required to maintain skin integrity in less than 32-week born neonates or more than 1200 grams birth weight. Generally, we start humidity as 60 to 80%. We keep them at 10 to 14 days because by the time skin get matures, and wean the humidity at 5 to 10% every 12 hours up to 30% of humidity. Okay, some other lesions of skin we need to remember. First thing is port wine stain. Okay, so what is port wine stain? Definition is previously asked. It is low flow vascular capillary malformation. So you have to remember this. Isolated or non-isolated generally found, but isolated port wine stain is most common. It is painless and pink. This is painless. You have to remember port wine stain is blanchable. You have to remember statement based question can be asked. It is mostly unilateral. No routine MRI of brain is required in asymptomatic facial stain. This was PYQ. In port wine stain, we generally don't require MRI, but you have to do eye examination for glaucoma. This is again very much important. Hemangioma we will discuss. So, just what see, hemangioma are divided into congenital hemangioma and infantile hemangioma. As name suggestive of, congenital hemangiomas are uh, that develops fully at birth. Okay, so congenital hemangioma develops fully at birth. They are classified as a rich, niche, and pitch. Rich is rapidly involuting congenital hemangioma. Niche is non-involuting congenital hemangioma, and pitch is partial involuting congenital hemangioma. These are classified as these. Why it is called rich? Because this is rapidly involuting. 75% of these congenital hemangioma they involute at around 14 months, and till then only emollients are required for treatment or cosmetic purpose, and rich are most common congenital hemangioma. So rich are most common, generally involutes around after 14 months, mostly 75% involutes, and emollients are used so generally in treatment of these. So these were rich. Okay, so what happened? Hepatic USG is required. This was PYQ. In congenital hemangioma, hepatic USG is required. So in rich, hepatic USG is required if lesions are large, more than 5 centimeter of multiple lesions that are more than 5. So lesions should be more than 5, and these should be more than 5 centimeters. If they are present, hepatic USG is required. But just see, GLUT1 is negative on IHC. Okay, so GLUT1 is used to differentiate infantile hemangioma from that congenital hemangioma. It is positive in infantile hemangioma and it is negative in congenital hemangioma. Very much important. Generally, cosmetic lasers can be used. Okay, pain, ulceration, thrombocytopenia can be complications. Okay, so going forward to infantile hemangioma. So this was PYQ. Most common vascular tumor of infancy is infantile hemangioma. They are generally actually divided into superficial, deep, and mixed hemangioma. Okay, these are two types of infantile hemangioma generally, some having low risk and high risk. Low risk are like superficial involvement, okay, and thin superficial focal. So focal, thin superficial will be considered low risk and other are in high risk. Okay, so first I'll go just understand treatment. The low risk of hemangioma will be treated as 0.5% timolol 1 drop BD for 6 to 9 months. High risk hemangioma propanol 1 to 3 milligram per kg per day for 6 to 12 months. Okay, now I'll understand them in detail. Okay, so they are not congenital, so that's why they appear after few weeks after birth. So not at birth. If they appear at birth, they will be called as congenital. Okay, GLUT1 is positive. We understood earlier also GLUT1 is negative in congenital hemangioma, but GLUT1 will be positive in infantile hemangioma. Premonitory telangiectatic lesion develop. Okay, generally this lesion grow and it involutes after 9 to 12 months. These infantile hemangioma generally involutes by 4 years of age. We have understood earlier that the one of type of congenital hemangioma that is rich generally involutes about 14 months of age, but these infantile hemangioma generally involutes at 4 years of age. Okay, if these infantile hemangiomas are present as facial regions, they will be part of FHACE syndrome. We'll discuss this syndrome in detail in some other lecture. And if they are actually associated with lumbar region, they will be lumbosacral region. They will be associated with lumbar, LUMBR. These are actually acronyms of some important syndrome associations. We will discuss them later. Okay. Hepatic USG is similar criteria if lesions are more than 5 and lesions are more than 5 centimeter in diameter. You have to do hepatic USG. Okay, so treatment generally start at 8 week of age. Treatment we just saw low risk 5% 0.5% timolol 1 drop BD for 6 to 9 months and high risk propanol 1 to 3 milligram per kg per day for 6 to 12 months. This is important. And conjunctive hypothyroidism occur in these patients. So if any neonate found like hypothyroidism, you have to see if it is not case of infantile hemangioma. Okay, so the treatment we have understood. Okay, the last slide, tuft of hair. So generally 50% of closed spinal dysraphism, this is tuft of hair, is seen, and it is MRI's investigation of choice if it is found in the lumbosacral region. Next, single umbilical artery. If it is isolated, generally it is benign. It is associated with like oligohydramnios, polyhydramnios, mortality. What you have to do in antenatal period, weekly antenatal fetal surveillance beginning at 36 weeks of gestation you have to do, and just after birth, detailed neurological examination is required. Periauricular tag is most common benign congenital ear anomaly. Okay, generally it is isolated is more common, and you have to monitor postnatal renal scan. Isolated periauricular tag does not need routine renal scan, but you have to consider them if your dysmorphic features are present. So this was it for retinopathy of prematurity, hearing screening, and some neonatal skin condition. Hope you like this video. If you like this video, do share, like, and subscribe. I'll try to complete other remaining part of neonatology in next lecture series.